Okay, welcome everyone to this SDSMA Center for Physician Resources presentation, The Physician's Guide to Effective Patient Communication. This presentation is brought to you in partnership with MMIC. Please note that we're going to keep all phone lines busy, so if you have questions, you're certainly welcome to ask those as we go through this presentation this evening. However, if we do start picking up a bunch of background noise, we'll go ahead and mute lines just so we can be respect our speaker as well. At this time, I want to introduce Robert Thompson with MMIC. Mr. Thompson has a diversified background in law, medicine, medical profession liability insurance, and healthcare risk management. Ms. Thompson also specializes in patient safety, risk management, and healthcare communication. And with that, Robert, I'll turn it over to you and let you lead us through this discussion.
I'll go ahead and get started right away here. Just as a starter, I want to stress and impress just how important patient communication is being recognized as in improving the quality of your patient's clinical outcomes and our interest as a mal provider comes in. We know that if you have better clinical outcomes, the chance of having a patient injury and a subsequent malpractice claim increases significantly. In about the last 18 months or so, our company has partnered with CRIO, which is the insuring arm for Harvard University, and we are now coding our malpractice claims. We have the last 3 years of our malpractice claims coded into their system. 650 different codes that we look at, clinical codes, not just financial codes. And what keeps coming up over and over in our data, mirroring and mimicking the data that CRIO and Stanford and a lot of other major systems have been waiting over the last 12 years or so, is that ineffective communication leads to patient injuries and malpractice claims. And so that's basically where this comes from, and being a movement toward education on patient communication and team communication. So with that, I'll get into the topics we're going to discuss today. Just briefly, we'll talk about risk management and malpractice. It's always a good idea to have an understanding of what we're seeing from the claims environment. So I'll talk for a couple of seconds about that. Then we'll talk about patient communication, 2 sides on patient orientation. We'll talk about 2 other topics, patient engagement and health literacy. You were at the South Dakota Medical Association annual conference out in Rapid City. I did a program that was specific to patient and team communication. So the first small section of this program will be the same, but the vast majority of it will get into that orientation, engagement, and health literacy aspect of the program. So the objectives for today are to recognize how a patient's perception of quality is based on the provider's ability to effectively communicate, how to avoid communication pitfalls that can lead to a medical liability claim, and to understand how the healthcare team as a whole plays a role in effective patient communication. And when I say the healthcare team, I mean the patient and the patient's family included in that, thereby the definition of patient and team and family engagement. As far as the definition of medical malpractice, these first 4 bullet points, the duty, the breach of that duty, the injury, and damages, those are the legal terms that are all required for a valid medical malpractice claim. But what I want to draw your attention to is bullet point number 5, what we call malpractice plus, or the X factor. This is a change in the manner in which plaintiffs' attorneys have been pursuing malpractice claims in the last 5 to 7 or so years. And this change basically has been a shift in focus from the purely clinical aspect of medicine to more of the service side of medicine. And these are non-clinical issues. These tend to be more procedure or process or communication issues. They are plaintiff's attorney's dream. They're very difficult to defend, and they're very difficult to explain. The main reason that we think we're seeing such a hard shift toward the side and service aspect of medicine is the American public, and thereby American juries, have a very difficult time understanding technical, clinical side of medicine. Even in a jury standpoint where you've got a battle of the experts, actually understanding the medicine is difficult. But if there's a communication breakdown or a process breakdown, a systems error, where a report was lost or a phone call was missed or misplaced, and a patient is injured in one of those instances, see that the American public is very unforgiving of that, and that the dollar value of those claims tends to be very expensive. There's a punishment factor to that. So that's why we think we are in this position with this shift toward the service side of medicine. What we see from a claims standpoint is that claims frequency is stable, so the number of malpractice claims being filed is staying about the same. For the last 5 or so years, we had seen a small decrease year over year in frequency, and it's just about stabilized. The flip side is that claim severity is on the rise. The value of the claims that are going through the system is heading up. Fortunately, 1 in 4 jury verdicts exceeds $1.2 million, and we expect that X factor, that focus on the service side of patient injuries, will continue to push that severity trend. A number of reasons for today's malpractice environment. That patients' expectations and abilities are different today than they were just a few short years ago, least of which is being pushed by the Affordable Care Act. Patients are looking at medicine as a purchase decision as opposed to a relationship, and that makes the focus on communication and relationships that's more important in your day-to-day practice. The side of the system, unfortunately, there's a certain percentage of the patient population, albeit small, that hopes to be malpracticed upon, that sees the malpractice system almost as a lottery, and very little that we can do about that. We know that when the economy is down, our business is a lot more robust, and that has a lot to do with the way society views the system and the way society views the dollar. It just isn't a buck anymore. Patients' perception of the value of a dollar has changed drastically, and that impacts our system. Some patients understand they have full and unabated access to their medical records, and that has caused a drive in nuisance claims, in fishing expeditions for malpractice claims for us. And then the Institute of Medicine report of 1999, that report that's still a stickler in the side of our industry, that stated that somewhere between 44 and 98,000 patients die each year due to medical error. That still is driving a lot of what we see from the malpractice environment. And that theme that I mentioned, that shift in focus from clinical issues to service lapses. That severity issue statistic that I gave you, where 1 in 4 jury verdicts exceeds $1.2. You can see some of these statistics pretty staggering. The point here is, these are shock verdicts, of course, but the point is that we're not protected like we used to be, although South Dakota tends to be one of the most protected states in the country, but not protected like we used to be. You can see this is a little closer to home. The last bullet point, the St. Louis County Circuit, 7 cases since the start of 2007 where the plaintiff was awarded $2 million or more. This was written in 2008, so 7 cases in about a 15-month period, and this was a good 6 years ago. So the multi-million-dollar verdict in this area of the country is unfortunately not something that's out of the question. It's a lot more common than we would like to recognize. Just some statistics, and not to scare you or to put a fear factor out there, but I want the understanding of malpractice to be realistic in the minds of the physicians in the areas that we insure, because this makes the fact that you can change tactics and the manner in which you communicate with your patients more prominent in your mind. When you can change a communication tact that can avoid the potential of a malpractice claim, I think you're more apt to make that change in your practice. So 7.4% of all physicians face a claim here. Indemnity payment in this study was almost $300,000, and that's indemnity, not with the cost of defense included in there. And the staggering statistic: by age 65, 75% of physicians in low-risk specialties will have faced a claim, and 89% of physicians in high-risk specialties will have faced a claim. The point, the rule here is that we're going to see a blending of what is a low-risk and what is a high-risk specialty. 10 years ago, the PIAA moved family practice to number 10 on its list of average indemnity paid by specialty. And the suspicion is that family practice will have moved up to around number 5 on the list. So it's pretty easy to make the argument that family practice physicians fall into a high-risk specialty in talking about indemnity paid. So
this is something that is faced by all physicians, no matter your specialty and no matter the area of the country in which you practice. So this is a chart showing the proportion of a physician's career spent with an open malpractice claim by specialty. Understand that neurosurgery and orthopedics and OB, those tend to be a lot higher and therefore a lot higher proportion. But still, there's a miserable way to go throughout a career when a good percentage of it is spent with the threat of a malpractice claim hanging over your head. And let's not forget that the average tail on a malpractice claim is about 5 years. So as opposed to an automobile accident where you wreck a car and 2 months later you're basically back in the position that you were before it happened, when it's a med mal claim, we're talking about 5 years. That's how long it takes to work through the system. And there's a huge emotional impact of medical errors and of malpractice claims on physicians. And this just gives you an idea of some of those. About 15% of physicians were involved in a medical error and a subsequent malpractice claim cited that they had issues with their reputation, that decreased satisfaction, they had sleeping problems, loss of confidence. Over 60% said they had issues with anxiety. So this is something that impacts your entire life. Some of the personal consequences of medical malpractice lawsuits, this was an interesting study of surgeons, and what they found is that those that were involved in a lawsuit, their attitudes were strongly related to burnout and depression and recent thoughts of suicide and less career satisfaction and less likely to recommend a medical career for their children. So, again, be impactful, and it can do something as simple as improving the quality of communication with our patients to keep this from becoming part of your life. Then by all means, let's go ahead and work at that. So with that being said, we'll move into the patient communication portion of the program, starting off with a little fun. Doctor talking to the patient says, "My, there's a typo. You were expecting the collagen injection in your lips and the liposuction on your hips." What we find is that the face-to-face patient interaction that you have is the most common medical procedure out there. The average physician will have this face-to-face patient interaction somewhere between 150,000 and 200,000 times in a career. And unfortunately, there's very limited training on it. There's very limited supervision in the early stages of a career on communication, on bedside manner. We're getting better than we have been in the past, but we don't focus on it like we should, especially considering the impact that quality communication can have on the clinical outcomes of your patient. So specific oversight in communication education as there are with other procedures. And we know that this common medical procedure, this interaction, is based in and relies upon quality communication. So patient communication is the single largest contributing factor to medical malpractice claims, and it is rather simplistic. Patients cannot pursue doctors that they communicate well with. I can't tell you how often I've seen scenarios where we have physicians that may have questionable clinical skills but spectacular communication skills and have never been sued in their entire career. And the other side of that coin is the tactfully proficient and competent physician, the clinically sound doctor that has a poor bedside manner and a very, very difficult time communicating with cohorts and his patients, that even though their medicine practice is great, end up in situations where they're commonly sued and a lot of times end up paying on those lawsuits. So it is rather simplistic, a lot more simplistically thought a few short years ago. And communication involves the entire team, physicians, administration, clinical and non-clinical staff. Impressing to your staff just how important their ability to communicate with patients is. It can't be overstated. The vast majority of the programs that I deliver on an annual basis are to staff members, to physician practice staff. Just the fact that what we call the 90-10 rule or 80-20 rule, the matter is your patients are going to spend more time with someone else in your office than they are with you. And so making sure that all of your staff, and that's both clinical and non-clinical, understand the importance of quality communication is a wonderful way to keep your patients healthy and to keep the potential for a malpractice suit down. Virtually all specialties, communication errors or barriers are the main factors resulting in medical malpractice claims, second only to errors in clinical judgment or technical error, what we call actual malpractice. The errors of clinical judgment or technical error are much more difficult for us to wrap our hands around. I go out and tell an OB babies better, but we have the ability to make significant improvements on communication capabilities. We've seen this not only in our own claim analysis and looking at those claims data, and this data is statistically significant. The data that we're working out of makes up over 30% of all claims reported to the National Practitioner Data Bank. So this is tens of thousands of malpractice claims. So we're able to prove that communication is negatively impacting clinical outcomes. And we've seen this transition from major national risk management and patient safety trade organizations where they're shifting their educational focus from the clinical aspects of care toward communication and culture, what I call the sides of the science. These statistics from CRICO data, what contributes most to OB claims, number 2 on the list, miscommunication at 36%. From a school standpoint, communication is third at 33%. And the only thing that ranks higher are those actual malpractice, the technical skills or the clinical judgment aspects of care. So this is just how important it is to the day-to-day practice of medicine. Those two that I just gave statistics on OB and surgery, we expect those high-risk procedure-based practices to have more clinical skill errors than in the more office-based practices too. So communication, I would argue, is even more important outside of the procedure-based practices. So as far as communication and claims in general, nearly 70% of all sentinel events name communication and teamwork as the root cause of the event, and every medical malpractice claim contains some sort of communication or teamwork error. An interesting study of patients who became plaintiffs in medical practice cases, and what they did was paid them for their honesty. And one simple question: why did you sue your doctor? So if your attitude was cited as 35% and lack of or poor communication was cited as 35%, that's 7% of all the malpractice claims out there cited attitude and communication as the reason that they filed the suit. Final incentives, only 10% cited that they did it for the money. Don't get me wrong, the 70% at the top, there was money at the end of the rainbow. I'm sure they weren't disappointed in it, but it wasn't the impetus. It wasn't the driving reason behind them filing the lawsuit. The community aspects and the attitude aspects were. More and more clear indicators that solid physician-patient communication skills lead to these things: more engaged patients involved more in their plan of care, patients' willingness to ask questions related to their treatment, patients abiding to their care plan after leaving the office, satisfaction with the care provided, lower costs, less time spent with your patients when your communication skills are good and you've got engaged in patients, and then increased trust and loyalty. And again, we all know that these lead to better clinical outcomes. The majority of these points that I make here we'll discuss at the end in the patient engagement portion of the program. So communication continues to increase in importance because patients are, I think they are, more prepared to research, particularly the WebMD and web-based type research. But these would be a positive for us and for healthcare providers. We recognize now just the opposite is true. It places a difficulty on healthcare when patients have incorrectly self-diagnosed, and we see that all too often. It sounds like I'm speaking out of both sides of my mouth here, that we want patients engaged, we want patients, be involved in their health care, and that's the truth. But we want that to come through competent communications and quality communications and relationship with their healthcare provider, sitting at home on a laptop for hours, thinking that they have whatever the issue is figured out. So, and this is something that we thought would be a positive that we recognize now has placed an even greater priority on communication capabilities and relationship building with your patient. Patients think they're more medically savvy. They tend to be more challenging of medical opinions than they have been in the past. And this last one can't be overlooked. They tend to be more consumer than patient. Again, that middle of purchasing healthcare as opposed to establishing a a relationship with a physician or a practice is a difficulty that I think is going to continue to place obstacles in our way as we head down the path of the Affordable Care Act. Some of the steps that you can do establishing quality patient communication skills, build for and setting the tone, eliciting concerns, and then setting the agenda. We'll go over these quickly. The first part of this, building rapport and setting the tone. I know that these things sound simplistic, as they are. These are the basic foundations of customer service, which have to be in place where you can ever be able to effectively communicate with your patients. They're simple things that all of your staff should hear about. I would suggest you putting a list of these on the bulletin board in the break room, making sure that your staff are doing these things with you also. Be prepared, greeting the patient, making eye contact, shaking hands, introducing yourself, using the patient's or the parent's name, learning everyone's role, smiling and being pleasant, making small talk, attend to the patient's comfort, ignoring the wait, if any. One of the single biggest patient complaints in office practice studies across the country is wait time. And wait time, simply acknowledging that wait, you go into the room, I'm sorry that you had to wait, we've got a big day. That tends to alleviate that stress right off the bat. Having front office staff say, okay, we're running 30 minutes behind, let's take cell phone numbers and ask the patients if they'd like to step out a cup of coffee. What I find is that most will just sit in your office and wait. It's not waiting, it's the not knowing, and simply by communicating with your patients, you can alleviate a lot of that stress, a lot of that pressure, and a lot of the problems that come from an patient who had to without knowing what was going on. Getting the knowledge of patient's history, the utilization of personal chart notes. This is getting more and more important as we get further down the road to full implementation of electronic health records. One of the negatives of EHR is that we have lost personal touch with our patients. The act of writing and of taking your own notes personalized patients to you, whether you realized it or not. And there have been some studies that look at how much a physician can remember about a patient. They read their own writing. And what those studies find is that physicians are able to recall a lot about patients that's even unrelated to the clinical that were in the record. They remember personal aspects of patients. And with the electronic health records, that's virtually gone. Your 1 o'clock, your 2 o'clock looks like your 3 o'clock. So anytime you can have some sort of personal chart note that personalizes you and your patient to you, it's very effective. My dentist came on one of my very first visits and asked me what I was up to. I told him I was going on a hunting trip. He just nodded, and then when I came in 8 months later, the very first thing that he asked me was how was my pheasant hunting trip, and I knew exactly what he was doing, but it was effective. It made me feel like I was one of just the few patients in his practice. These sit-stand studies, make sure that you're sitting down when you talk to your patients. In these studies, they polled patients coming out of rooms, and what they had done was instructed half of the physicians to sit down and half of the physicians to stand up. And what they found is even though the interactions with the patients were virtually identical, the patient's perception of the length of time that the doctor spent with them doubled when the doctor sat down. So little things that you can do that change the patient's perception of the interaction, that start to set that rapport and build the tone to allow you to communicate better with your patient. Make eye contact, explaining the EHR simply by saying, we're using EHR, it's much more effective for us, it's better for you, but I have to look at the keyboard while I'm talking to you, but rather I'm listening to everything that you say. So concerns, number 2 on the list, asking with a beginner's mind using ILS. I for invite, what can we address today? L for listening with quiet curiosity, and then S for summarizing and checking. Number 2 on this list, L, listen with quiet curiosity, is far away the most important of the 3. These are studies that I've used in my programs for about the last 10 years. They actually started back in 1984. Doctors Beckman and Frankel were trying to look at communication skills that physicians have and how well they communicate with patients. And one of the things they were recognizing was that physicians tend not to allow their patients to talk. They asked the question, how long on average does the physician allow a patient to talk before they first interrupt or interject. When they formed their studies, they found that the average was somewhere around 16 seconds. So, and in some studies, much shorter than that. And what we know is that instantaneous interjection into the patient's communicating with you completely changes the dynamic of the conversation. It goes from a patient-driven conversation to a provider-driven conversation. So you find yourself in a situation where you're dealing with much more pure clinical information, because patients have to get to the good stuff first. They have to warm up a little bit, and the good information is the information that was going to come had you allowed your patients talk. From a patient's perception point, they feel like they didn't get their money's worth, that they didn't get to say their piece, that they didn't get to get engaged or involved or participatory in their relationship and in their meeting with their physician. And a lot of times after that first interjection, they just shut down. And so in this same group of studies, the authors of the study instructed a certain number of the physicians to their patients to talk uninterrupted until they'd said everything that they have to say. And what they found is that if you do, your patients will talk on average for only about 2 minutes. But again, if you allow them that extra minute and 45 seconds, you end up being much more efficient from a time standpoint, end up dealing with much better clinical information, much purer clinical information. It also allows you to shuffle the deck. You get to set the agenda when everything's out on the table. What we did is that your patient will present on average with about 3 or 4 concerns in the outpatient setting, and getting all of those out on the table early allows for you to correctly prioritize. It avoids that crushing chest pain complaint as the one final thing, where the patient talks to you about the pain in their elbow for 13 minutes, and then when you're just about to walk out the door, they bring up the real problem. Like I said, it actually makes you more efficient. So setting an agenda, avoid the premature diving. When needed, ask what else. Summarize the list of patients' concerns that have, and then introduce your own agenda items. The patient's priorities, state your clinical concerns, and throw your plan out there. Like I said, simply allowing your patients to talk for 2 minutes, and I hope that everyone listening tonight will make that a priority in their practice. You find that you're much more efficient, that you're dealing with much happier patients, that the visits tend to be much smoother, and that you'll start to see better clinical outcomes from your patient. So a couple of slides on patient orientation. I think that this is one of the overlooked risk management tools available to you. Very few patients are able to actually evaluate how well you do what you do from a clinical standpoint, and so the quality of care is often judged on the personal interactions, on the communication capabilities, on the attitudes of you and your staff. And patients have no idea how a medical office actually operates. There's a couple of outliers here. Pediatrics, because the patients are routine visitors, OB because the patients are routine visitors, and geriatrics because they tend to be in the office a little bit more. Other than that, and other than your frequent flyers, your standard patient, your average everyday patient, has no idea how your office operates. And procedure, the basics of the flow of your office is taken for granted by most physicians and by the staff, because it's something that you do on a day-to-day basis. Most of you, the process and the flow of your office seems like a well-oiled machine, and I don't argue that it is, but for most patients, that process seems chaotic, and we talk to them about what they should expect. Or patients is the responsibility of the entire staff, and it's as simple telling your patients what they should expect and how long it should take. This is where we're going to take you here into the triage room. We're going to take your blood pressure, your temperature, your weight. Then we're going to move you into a treatment room. Explain that what may come in, that X-ray may come in, the simple things of how the process of visit should work. If you do that, you'll find patients that are on board, patients that are engaged, patients that are involved, and again, you'll see an ease in the flow of your office. Something you can do, use staff brochures in the waiting room, introducing everyone in the office so that there's a little bit of an ease in the relationship when they meet face to face. Make sure that you're supplying directions to your office. Again, explaining that basic flow. then I mentioned wait times before. Monitoring wait times and giving updates when appropriate. It's not wait, but it's the not knowing. A number of practices that are using a chart diagram of their waiting room with numbers on the chairs, and when Mrs. Jones comes in and checks in at 10:04 and sits down in seat number 6, sit down Miss Jones, seat number 6, 10:04 on the map, and he's been sitting there for 20 minutes. Someone actually gets up and comes from behind the desk and walks out and says, "Miss Jones, just want to let you know we haven't forgotten about you." Something that simple completely changes the mentality, the attitude, the participatory nature of your patients. So into patient and family engagement. What is patient and family engagement? I'm sure that you all have heard this buzzword going around. We've seen a movement in this. Recently, we're going to hear more and more about it, and we think that this is going to be a positive as we head down the path in the future. Engagement is patients, families, their representatives, and healthcare professionals working in active partnership at various levels across the healthcare system, direct care, organizational design, and governance and policy making, with the goal of improving health and healthcare. So what we'll focus on today is that direct care aspect. The organizational design and governance and policy making side is still off in the future, and it's pretty lofty from a goal standpoint. But promoting that active partnership in the direct care portion of what we do, know improves health and healthcare, and we know makes for better patients and less patient injuries. So one common sources of patient dissatisfaction is not feeling properly informed about and involved in their treatment. Got to be focusing on shared decision making, on partnering with our patients, on participating from our patients and collaboration with our patients. And these buzzwords are out there, and so often I hear buzzwords and think, this is just another phase, another fad. But I've seen the positive effects from all of these four. I know that we can be better when we work in a partnership as opposed to a non-partner relationship. So patient and family engagement, there's a number of reasons. Involving patients and utilizing, and I want to make a point here. When I'm doing my research on patient engagement, I was under the impression that this was all about how do we get these people involved? How do we stress to them that this is their health, that their health care, that they be involved? It is as much about us as healthcare providers accepting the relationship from our patients, accepting the fact that patients are participants in their health care. We have done a poor job of allowing patients in, even though in large numbers they have been knocking at the door for years. So patient engagement isn't saying, how can we get these people on board, much as it is saying, how do we form a partnership and utilize the resources that the patients are capable of bringing to the table. So with that as a preface, I'll move on into this. So patient and family engagement. Patients, families, they can serve as an extra set of eyes and ears for us. Let's utilize that resource. They're invested in their well-being and their health. Who should be more concerned about their well-being and about their health than the patient or the patient's family? They know their systems, their recent transition and changes, and their responses to treatment better than anyone else. The more that we allow them to be involved, the more that they will focus on being aware of their symptoms and transitions and changes. Unless I'm impaired, let's just talk about being present. Patients are always present in their own care, and sometimes the first ones to recognize changes and impacts of treatment. Patients all have only one patient to focus on. It's them. When you're talking about a family, it's a family focusing on their member as a patient. And therefore, they have insights into the process of care. Busy professionals, nurses and doctors that are seeing 30, 35, 40 patients a day, never have it. Sometimes the process and the work-a-day world gets in the way of recognizing something that's glaring and right in front of you. Through Resilience, patients and their family inspire and energize care teams. what we did is that in those organizations where there is a palpable patient-friendly engagement, you don't only have happier patients, but you have much happier staff members and physicians and healthcare providers in general. If patients are truly members of the healthcare team, they can more effectively protect themselves from errors and process failures that cause injuries. I can't tell you how many practice claims I've seen where something happened to a patient and the patient just didn't feel empowered enough, even though they thought, this isn't right. They just didn't feel empowered enough or engaged enough or didn't feel the relationship was open enough for them to be able to speak up, and ended up in a bad situation with a bad patient injury when had we done a better job of opening that door and promoting this relationship and this partnership, that medical error likely never would have occurred. So family engagement involves and benefits everyone. Increasing engagement through effective partnerships can yield many benefits, both in the form of improved health outcomes for individuals and in safer and more productive work environments for healthcare professionals. And those studies show engagement is in for everyone. Engagement of patients makes engaged healthcare providers. It has that kumbaya feeling to it when everyone gets on board. Engage to safer patient care by improving the outcomes of care, improving the experience of care for individual patients, improving the work experience for caregivers, and also helping the organization change its process, improving the outcomes for all patients. If we that are able to spot an issue that could have or did cause a problem, by having them involved and engaged, we can fix that for patients going forward, which, by the way, in the process of and apology is one of the four things that patients absolutely require, is making sure that what happened to them happened to someone else. Patients want to make the system better. So improving the outcomes of care, patients can participation in diagnosis, the clear communication, the full story, and the accurate history. Again, patients are able to talk if they're able to tell their story, if they're participating in that back and forth dialogue early in the diagnosis process. You're dealing with much better clinical information. From a shared decision-making standpoint, patients are more participatory in healthcare when they have input into the decision-making. If this is, I'm going to tell you what to do, well, it seems easy to sit back and just listen. Whereas if the conversation is couched in, let's decide how we're going to walk this path or which path we're going to take, these patients that are much more involved. Following the treatment plan, lack of engagement equals lack of compliance and adherence, and we know that leads to poor outcomes and to a waste of time and resources. And then let's not forget the extra set of eyes that I mentioned. Patient participation increases quality of care and reduces the incidence of adverse events, period. The experience of partnerships, patients desire that relationship, and oftentimes it's difficult for them to stress that or to voice that. And so we often need to be the drivers in forming a partnership. They desire trust and partnership, and they want providers to work with us, not on us. Improve satisfaction with outcomes. Patients who make decisions based on their preference and values are more satisfied with their clinical outcomes, and the relationship between patients' experience and a culture of safety, centered care and patient engagement are closely aligned. And because we heard so much about patient-centered care over the last 4 or 5 years, we're going to dovetail that into patient engagement. I think we'll hear about them both mentioned together a lot more often than we have recently. Some barriers that we see to patient and family engagement: health literacy problems and issues, which I'm going to discuss below on the last 4 slides or so of the program. Understanding the terms of engagement and safety. As patients, we tend to remain uninformed, passive, and lack confidence and skill to fully engage. We're never going to be able to do a whole lot about the skill side of things, and that's just a fact. We can't expect that patients are going to be completely versed on the technical aspects of clinical medicine. But we can do something about uninformed, passive, and low confidence patients. We can impact that by opening that door, by inviting patients in. I think that we can overcome some of the inability to grasp the skill from a technical standpoint just having patients involved. Social support for vulnerable patients, the elderly, the mentally ill, and economically disadvantaged have more inherent barriers to engagement. They're the ones that are going to be more difficult to work on. Those are going to be the ones that are going to be less likely to accept that invite. But the sad fact is that those are the ones that need the patient engagement even more so than the ones who actively want to come in the door when we open it. Barriers to engagement, fear of retribution from healthcare providers. Even patients with high levels of health literacy are intimidated to ask questions or probe alternatives. And that's the fact. I've seen it time and time again, where we've got folks who you would think would have been involved and would have been first to ask questions and just not muster up that courage to do so. Some other factors include the paternalistic behavior of healthcare providers, something that's been inherent in the system for years, the prevailing social norm that patients don't challenge advice. I had a slide at the beginning of this program where patients tend to be more challenging of opinion. I'm talking out of both sides of my mouth. We want to make sure that we're involving patients so that they're participatory. That doesn't mean that challenging, the negative aspect of challenging, is something that can still be a problem for us. That they're being labeled a difficult patient, or the fear of speaking up will lead to neglect or abuse or the termination of the relationship with their physicians. So recommendations that we've got to promote patient and family engagement as far as healthcare clinicians and staff. Support patients and families to engage in their own care. And these are some things that you can use in your office on a daily basis, hopefully something you can take back and implement immediately. Routine involve patients in informed decision-making about all diagnostic tests and treatment options, including medications. Use strategies such as Ask Me 3, which I'll talk about in a second, and Teach Back to overcome health literacy barriers and to ensure that patients truly do understand their condition, what they do next, and why it's important to do so. Improve on patients that you desire, require, and value their opinion, their questions, and their input when it comes to their care. Just implementing a simple statement like that into the conversation that you have with every patient, saying, I desire, require, and value your opinion and questions and input when it comes to our partnership that we have. Something along those lines is the first step in breaking those barriers and in opening that door to your patients. Some recommendations: remember the Beckman-Frankel studies. Allow your patients to participate, allow them to talk. Make that a commitment in your practice, and I think that you'll find that it becomes much easier to get that engagement from your patients. Waiting room pre-visit problem forms. I've seen these used effectively, and this is something that's very recent, where when the patient checks in, the office staff hands them a little piece of paper that says, the top 4 things that you'd like to talk to me about. So that automatically gets the patient thinking, automatically gets the patient engaged. It allows you as a physician to almost have a head start when they get back into the room. Again, from an efficiency standpoint, being able to fill that deck really puts you ahead of the curve from a time standpoint with your patient. And I mentioned a couple of seconds ago the Ask Me 3 campaign through the National Patient Safety Foundation. What it is and you can look this up on the internet through the NPSF website. It's posters or cards that are placed throughout your office that promote patients to ask these 3 questions. What's my main problem? What do I need to do? And why is it important for me to do this? Simplistic, sounds simple, but this is that trigger. This is the point we're trying to get patients involved, and keeping it simple like this allows the conversation to start. And what we find is that simply by asking these 3 questions, the participation, the partnership tends to start forming. So what's my main problem? What do I need to do? Why is it important for me to do this? And you can find these resources, the available at the National Patient Safety Foundation. Those recommendations, further recommendations, support patients and families when things do unfortunately go wrong, creating healing environments that include a physical setting and an organizational culture that supports patients and families through the stresses imposed on illness, hospitalization, medical visits, healing, and bereavement. Next on that list, support and be willing to participate in disclosure and apology initiatives, both development and implementation phase. As an organization, MMIC is coming up with our position statement on disclosure and apology. This is a movement, obviously, for 10 or 12 years in healthcare. It's kind of ironic that it was the medical industry that started the problems with failure to disclose and with apology. And this has come full circle, and we appreciate the need to be able to freely boast to patients and to apologize to patients when appropriate. And so we're working on this ourselves. I think that the further we get down the road to having a more transparent approach when things do unfortunately go wrong, the easier it is to maintain the relationship, to maintain that engagement with your patient. I would suggest that you take a look at potentially something as simple as this on your walls in your waiting rooms or in your treatment rooms. You know, because it's going to be patient engagement. It's not just coming from physicians and staff. It also has to come from the patients and their families. What can they do to make care more safe? You know, asking questions about the risks and benefits of recommendations until they understand the answers. Don't alone to your hospital or to doctor's visits. Always know why and how you take your medications and their names. Be sure that the patients understand the plan of action for their care. Talk back, teach back, or say back to clinicians in your own words what you think they have told you. Patients arrange to get any recommended lab tests done for a visit. Patients to determine who is in charge of their care. You know, again, that's a list that you can put on the walls and say, you know, these are things that we would ask that you do as far as your half of the partnership. Something as simple as that, I think, can really get this ball rolling and get the flow working on engagement. Important to me. Talk just for a couple of minutes. Health literacy issues and suggestions. Literacy, the inability to read, understand, and act on health information is a hidden epidemic that affects nearly 1 in every 3 people in the U.S. The average American reads on a 5th grade reading level. Most healthcare literature is written on an 18th grade reading level. So the average American reads on a 5th grade reading level, and 12% of English-speaking adults are proficiently health literate. So these statistics are quite staggering, but this is what we face on a daily basis in medicine. Even college-educated patients have difficulty understanding complex health information given them by physicians, and lack of literacy skills leave patients unable to effectively manage their personal health, poses a significant threat to patient safety. So some suggestions. Patients, remember that patients with low health literacy can be any ethnicity or age. In fact, most low health literacy patients are white native-born Americans. Literacy is not a reflection of intelligence. Again, back to the college-educated persons that still have the inability to grasp the mental aspect of what they're participating in as a patient. So patients with low health literacy from all segments of society, there's a greater proportion among the older adults, people with limited education, and those with limited proficiency. So this will just give you an idea. Low and marginally literate patients have difficulty following the prescription label instructions, as well as take 2 tablets by mouth daily, even when they are able to read the instructions correctly. So in literacy, 7% were able to read the instructions correctly, but 34% of those could demonstrate the label instructions correctly. Again, that's a pretty simple. Take 2 tablets by mouth daily. Marginal literacy, 84% could read it. It jumped to 62% could actually demonstrate it. And then added literacy, 9% could read. the instructions, and almost 80% could demonstrate the instructions correctly. And it's pretty scary when you think about the simplicity of those instructions. Our next little funny for the day on health literacy. Certainly there, but if you think about it, I mean, what more technical language is used in this country than medical terminology? Just go look at medication lists, and that'll give you an idea. Another example, when you look at this, it just looks like gibberish, but read it backwards. We all have trouble understanding sometimes. It's important, I think, to step back and look at the perspective from the patient's view. So, health literacy issues, it is all about the ability to effectively communicate. Some suggestions here, and definitely not rocket science, but try to keep these in mind. Use lay terms, not medical jargon. Choose simple, not complex words. Use short sentences whenever possible. Patient actions and behavior. Invite family members to participate in patient visits. Information to previous knowledge that your patients have. Tailor information that you're giving to your patients to that individual patient, using pictures or diagrams at any point in time when you can to improve comprehension. Use teach-back techniques. These are really, really effective just by telling a patient something and then saying, tell me what you understand that I just said, or say this back to me the way you, tell me what you heard me say. Use 2 or 3 new concepts at a time. Much more than that, we're just not able to hold it in our minds. Read information aloud and slowly to patients when you can, and making sure providing interpreters for patients with limited English proficiency, and translate frequently used written education materials into other languages. We actually have some to do this. If you're an MIC insured on our website, it's striking what you can translate into multiple different languages. Swahili, all of the Eastern European languages, African languages, can be translated on a website, a relationship that we have with a company who we with recognizing limited English proficiency and ways that we could get around it. I hope that some of this information has been beneficial. I apologize for my voice. I'm trying to catch a cold here, but I hope that there's actually some resources that you can take back and apply at your practice. And if you've got any questions about this or any other risk management and patient safety, I'd be happy to answer them for you.
Okay, Robert, is there any questions for Robert at this time? Okay, hearing none. Well, Robert, as always, I think you've been very good about anybody that has any follow-up questions, they can contact you. Would you mind sharing your contact information?
Absolutely. It's robert.thompson, mmicgroup.com. Feel free to shoot out any questions that you got. I'd be happy to answer.
Okay. And we'll do one last call. Any questions for Robert before we wrap up? Okay, none. Well, Robert, I do want to thank you for taking your time today to give us this presentation. I think you presented some very good information, gives us lots to think about, and so we do thank you for that. And then the last thing I want to mention before we draw this evening to a close is that in November, we will be holding our next program, and I believe in November we are scheduled to talk about patient handoffs. And so I know that that's a topic for many people, and it's also another area which there's a great liability or a great potential for risk and liability. And so in November, we'll spend an hour together talking about patient handoffs and how to mitigate risk in those transitions. With that, we thank you all for attending.
Thank you.
Thank you.